But again, I'd like to welcome all of you. It is really an honor and pleasure for me to be here and to introduce this wonderful panel. But tonight is, I think, the first of 4 lecture series that showcases some of the great work being done at UCSF, both scientifically and how it translates into clinical care. And this is a very popular program. I see many, I'm one of the busiest surgeons at UCSF, and probably the most common question asked me is not only, first is what do I do about my prostate cancer, but secondly is how do I eat better or exercise? It's amazing to me that the amount of questions we get on that. And probably about a decade ago, we started a program where we felt we really need to have a nutrition program at UCSF that could advise patients in a very structured, professional way. And we've been blessed to have that here at UCSF. And if you'd asked me 15 years ago or 20 years ago, would diet be a prescription for prevention or cancer care, I wouldn't have thought so. And if you'd asked me 5 years ago, and I'm an avid runner, but if you'd asked me 5 years ago, would I think that we'd be giving prescriptions for exercise for cancer patients, I wouldn't have believed it. But at UCSF now, both nutrition and exercise are being offered to patients, and our panel will talk about that. So I'm going to let the panel start off. I'm going to have each panel member introduce themselves, say who they are, what do they do, and how did they get here to UCSF to talk about nutrition, exercise, and survivorship. So I'll invite Greta to come up first.
Okay. Thank you, Dr. Carroll. And can everybody hear me okay? Okay, great. So my name is Greta McCare, and I'm a registered dietitian at the UCSF Cancer Center. And I work with patients on a day-to-day basis, providing individual nutrition counseling and also monthly group classes on various nutrition and cancer-related topics. I'm going to start out, let me just move this a little closer so it's a little easier. So I'm basically just going to spend a few minutes talking about the American Institute for Cancer Research Guidelines for Cancer Prevention. And the AICR is an organization whose mission is to study the effects of lifestyle on cancer risk. And they've basically reviewed thousands of studies conducted all over the world and developed a set of recommendations that we can use to follow to reduce the risk of cancer. We do know that about 30% of cancers can be attributed to tobacco use, so their number one recommendation is to avoid smoking or chewing tobacco. Another 30% of cancers can be attributed to obesity, a sedentary lifestyle, and a poor diet. And so their second major recommendation is that we should be exercising for at least 30 minutes a day, 5 or more days a week. They recommend that we limit sedentary activities. So these are things like TV time, computer time, screen time. Their third recommendation is that we avoid foods high in added sugar, added fats, or energy-dense foods. So these are things like fried food, fast food, excessive intake of desserts. And they really put an emphasis on avoiding sugar-sweetened beverages. So these are things like sodas, fruit drinks, fruit juices, because sugar-sweetened beverages tend to have the greatest impact on promoting weight gain and increasing obesity. Their fourth recommendation is that we aim to eat a predominantly plant-based diet, emphasizing a variety of minimally processed plant foods, such as vegetables, fruits, whole grains, beans, and legumes. So things like tofu, garbanzo beans, black beans, any kind of bean or legume. With much more of an emphasis on nutrient-dense plant foods and less of an emphasis on animal-based foods such as meat and dairy products. Their main emphasis on limiting meats and dairy products really are surrounding limiting red meat and avoiding processed meats. Processed meats are meats that are either cured or smoked or preserved with chemicals that we know of as nitrates or nitrites. And those would be things like hot dogs, bologna, bacon, any kind of cured meat, lunch meat such as bologna, for example. And the biggest effect is with processed meat, so it's really recommended to avoid those altogether, really limit them to very special occasion foods, whereas the guidelines with red meat are generally around limiting red meat. Their next recommendation is around alcohol, and so they recommend that we limit alcohol for men to no more than 2 drinks a day, and for women to no more than 1 drink a day. And so what is a drink? A drink is the equivalent of 5 ounces of wine, 12 ounces of beer, or 1.5 ounces of spirits or hard liquor. They recommend that we limit processed foods high in sodium. So again, that would be cured meats, salted fish, and other foods high in sodium, such as canned soups. And their other recommendation here that you see is obtain nutrients from foods, not supplements. And when they've reviewed studies worldwide, thousands of studies, they really haven't seen any significant risk reduction regarding cancer with any particular micronutrient supplement. So there's no reduced risk associated with taking a certain vitamin or certain mineral. And in some cases, they've even seen an increased risk of cancer with individual micronutrient supplements. So ideally obtaining, whenever possible, the nutrients we need from our diet in sort of the natural physiological amounts and forms that we are meant to obtain them. So what about for cancer survivors? So they have developed, they have been looking more at the research for people once they've been diagnosed with cancer. But really, a lot less is known about diet and exercise and the effects of those lifestyle habits after a diagnosis. And but based on the current knowledge, cancer survivors are recommended to follow the recommendations for cancer prevention. And the studies that have been done to date have shown that following the guidelines for prevention are associated with better overall quality of life and better overall health for people after a cancer diagnosis. UCSF is working to advance survivorship care and research, and we want to tell you a little bit more about the work we're doing in that area tonight. So, the American Institute for Cancer Research really gives us these good general guidelines to follow, and then we're looking more at how we can apply those to cancer survivors and what our research can tell us about how those recommendations can affect people after a diagnosis. So I'm going to introduce Dr. Catherine Van Loon, and she's going to continue on the discussion talking about survivorship.
Thanks, Greta. My name is Catherine Van Loon. I am a medical oncologist and faculty member in the gastrointestinal oncology program here at UCSF. My clinical expertise is in the management of colorectal cancer predominantly, although I treat a variety of different gastrointestinal malignancies. And I have a research focus that is based upon surveillance patterns, recurrence patterns for our colorectal cancer survivors and neuroendocrine tumor survivors, as well as how we implement all of the things that Greta has mentioned in terms of lifestyle and dietary modifications that our patients can do. How do we actually enhance our patients' ability to comply with those following completion of cancer treatment? So advances in technology and cancer treatments have led to pretty dramatic increases in cancer survival. Currently in the US, approximately 14 million people identify themselves as cancer survivors. And this number, with the increases in cancer therapies as well as in the aging of the baby boomer population, is expected to increase to 18 million by 2022. These are pretty overwhelming numbers. Cancer survivorship is defined as the phase of the cancer continuum after completion of active treatment. And as an oncologist, I think of it as the moment when I sit with a patient after their completion of treatment and help them think about how do we move forward and what does life after cancer mean. Both how do I take care of you, but also how does the patient and the family move forward in their lives. In response to increasing demands from patients as well as national mandates, the Helen Diller Family Comprehensive Cancer Center has committed itself to improving the standard of care that we're providing to our long-term survivors, and improving the follow-up care that we provide to our patients, addressing the long-term effects of cancer and its treatments. Oh, sorry. Am I? Okay. There's nothing too brilliant on there. So what is survivorship care? Cancer survivors have a long list of unique physical, medical, psychological, social, spiritual, and informational needs that are currently, I believe, inadequately addressed by current standards of care for cancer survivors. Issues that are unique to cancer survivors include weight management, fatigue, sexual health, depression, body image issues related to previous surgical interventions, and a lot of patients face a lot of anxiety that is particularly triggered by surveillance and follow-ups with their oncologists. In order to address all of these medical and non-medical issues, survivorship programs need to be multidisciplinary. This is, on the right-hand side of this slide, this is a sort of cursory overview of what many survivorship programs look like, with nurse practitioners coordinating and managing programs, and being integrated into cancer care from the time of diagnosis through long-term survivorship. Psycho-oncology specialists provide lifestyle support and address anxiety and depression concerns of patients, and nutritionists ensure patients' dietary needs are properly managed. This is a diagram that the Institute of Medicine put out in 2006 with the 4 recommended components of survivorship care. Survivorship care should include prevention of recurrence and prevention of new secondary cancers and late toxicities. It should include surveillance for metastatic recurrences, secondary cancers, as well as surveillance for the medical and psychosocial late effects of previous cancer treatments. It should include intervention for the impacts of cancer and its treatments, and it should require coordination of care between specialists and primary care providers.
Yeah, excuse me, I think I know, but what is psychosocial late effects?
So I think probably in that, it probably encompasses anxiety related to recurrence, concerns and fears about recurrence, which a lot of cancer survivors are really carry forward even much longer than recurrence patterns actually dictate that they should. Depression, body dysmorphic issues, as well as sort of self-esteem issues. And this is a complicated slide, but it basically illustrates the spectrum of survivorship care program structures that is available. So on the left, bare bones structures, and then ranging all the way to an advanced survivorship care program where there's a dedicated mid-level provider who leads the program, sees patients, coordinates care. There are dedicated staff that are hired and trained for the program. MDs are aware of and are actively engaged and informed about the ongoings of a survivorship program. It reaches all patients in the cancer center. It provides a treatment plan that's delivered and explained in a provider setting rather than just handing the person a piece of paper with a treatment plan. And it provides regular, early, and two-way, high-touch dialogue between the cancer team and primary care providers. This is a more complicated slide than the one I showed you previously, but illustrates a vision for survivorship care here at Helen Diller Family Comprehensive Cancer Center. And it draws upon the wealth of resources that currently exist at this university and within the cancer center, but puts them under a common umbrella of survivorship, where a nurse practitioner would coordinate care with primary oncologists from diagnosis through long-term survivorship, and then integrate a multidisciplinary team from psycho-oncology, physical therapy, integrative oncology, or as many of you are familiar with, the Osher Center, nutrition, our symptom management team, as well as our genetic risk counselors. And then in the very bottom, the rest of our talk is going to be dedicated to embedded research infrastructure that we envision as part of this going forward, where we have clinical research coordinators, longitudinal data collection tools, and chronological data that's being collected on all of our cancer patients and their symptoms. By definition, cancer survivorship research is research that is dedicated to physical and psychosocial sequelae of cancer diagnosis and its treatment, or healthcare delivery, access, and follow-up care, or behavioral research that to look at how we improve uptake of recommended lifestyle and dietary modifications. I'm going to finish my talk with just a short illustration of how we're approaching this within colorectal cancer. So just as background, colorectal cancer patients comprise about 10% of all cancer survivors within the US. So it's a large population that is very underserved currently. For colorectal cancer survivors, there is emerging strong evidence that the following may reduce recurrence risk. So as Greta talked about, adherence to a non-Western pattern diet and exercise. There is emerging data that vitamin D levels and vitamin D sufficiency are associated with a reduced recurrence risk. For a subset of patients with a particular mutation called a PI3 kinase mutation, chronic aspirin exposure may be associated with reduced recurrence risk and avoidance of sugary beverages. In addition, colorectal cancer survivors experience very unique long-term toxicities that may be distinct from what, for example, a breast cancer patient experiences. Many have peripheral sensory neuropathy as a long-term toxicity. Many experience bowel discontinuity due to surgical procedures that they undergo for resection of a primary tumor. And for our rectal cancer survivors, sexual dysfunction after radiation is a significant issue. Still, there's very little evidence about how we manage these chronic lifestyle issues and how we integrate the dietary recommendations into the care of our patients. And specifically, I'm interested in looking at how these issues impact adherence to physician recommendations about diet and exercise. Our goal is to understand chronic issues that our patients face and identify strategies to improve survivor care. And these are 4 examples of protocols that are in various phases of development within our research program. We are constructing a longitudinal database that measures lifestyle behaviors, symptoms, quality of life, and clinical outcomes. We are conducting focus groups that will explore and identify unique survivorship issues by talking to patients in a safe and a safe environment without oncologists present. We have proposed a clinical trial of cognitive behavioral intervention to improve adherence to diet and exercise guidelines. And Erin is next going to talk with you about her development of mobile technology intervention to promote physical activity in our survivor population.
Sorry, one other question. Longitudinal database, is that gathering data over time?
Yes. So that basically means that from the time the patient first comes to our clinic, we enroll them in a database and periodically are collecting data about various measures. So either psychosocial stress, quality of life, or actual toxicities of their treatment.
Do you gather data about their adherence to some of the recommendations you talked about today?
Currently, no. That is actually one of the things that Erin's going to talk with you about, but it's something that we're pretty interested in looking at.
There's an app for that. Okay, thanks.
Were those measures only for colorectal cancer or other cancers that you treat at UCSF?
What do you mean, measures?
The one that you talked
So
about.
this is an example of what's happening within the GI oncology program. Erin and June are going to talk with you about what's happening in some of the other programs.
The recommendations, you're talking about the aspirin and the vitamin D, those are specific for colorectal cancer survivorship.
That was my,
Yeah, so Greta spoke to recommendations more broadly for all cancer survivor, and the ones that I put up there were sort of meant to illustrate that even within cancer survivors, there are specific guidelines for specific types.
Yeah, so thank you, Dr. Van Loon. So my name's Erin Van Blargen, and so I'm a nutritional epidemiologist, and I'm in the Department of Epidemiology and Biostatistics and Department of Urology here at UCSF. I also work a lot with the GI oncology group as well. So I'll be talking both about projects going on in prostate and colon cancer. And so Catherine gave us a good context in which now myself and Dr. Chan do research on specific things to try and better understand how diet and exercise may influence both the biology of tumors as well as survival, and helping build tools so that patients can learn about these things and make dietary or exercise habit changes and maintain them over time. So one of the new interests for us is to help with this behavior change and education through mobile tools, like using your cell phone or apps or websites to inform patients and support these changes over time. And so I'm going to talk about some specific studies that we have going on right now. And each time I'll give a little bit of background of some of the science behind it and why we chose that particular topic. So for some background, first is physical activity in colon cancer. And so this is data from a study that looked at physical activity levels after you were diagnosed. And so the important thing is basically on the Y, it's just telling you the relative risk of mortality. And then the x-axis here is the amount of activity. So the higher your activity levels, the lower your risk of mortality. And in this study, actually, women who reported, it's called MET hours per week, but basically this is roughly 3 hours of jogging per week, had 57% lower risk of dying from their colorectal cancer. And so this is behavior after they were diagnosed, and it actually was independent of the amount they did before. So, and women who had increased their activity from what they did before had also a 50% lower risk, no matter what level they had before. So with this really strong data, which has now been seen in a couple different studies, we developed a trial here at UCSF to help colorectal cancer patients increase their physical activity. So this is just beginning this winter. I'm working on it with Dr. Van Loon and Dr. Van Nook, who was here earlier. And our goal is to see if we educate patients and provide them with physical activity trackers and send text messages, that we can both help people get a better sense of how active they are currently, and then maybe increase that if needed to meet the recommended levels. And so this is a study that will be enrolling about 40 men and women here at UCSF who had stage 2 or 3 colorectal cancer. And then for prostate cancer, this is some data, another study we have. So this is looking at vegetable fat intake after diagnosis. And so vegetable fat is, fat from any vegetable sources, but in this study it's mostly from olive oil and nuts. And so men with prostate cancer who consumed more of these foods after they were diagnosed had a lower risk of mortality. So the line, I should have mentioned this on the last slide, but the line there across for 1 is basically showing no effect. So if it's below, then the risk is lower. If it's above, then the risk is higher. And so in this study, men who consumed, if you substituted 10% of your calories were with carbohydrate, instead you ate vegetable fat, you lowered your risk of dying from prostate cancer by 26%. Did I hear a question? Sorry. Do you have a question?
How much is for Q4?
Yeah, so that's a good question. So those are quintiles, so it's chunked out, so there's an even number of people in each group. What you can see is so it'd be 10% of your daily calories, or say you ate 2,000 calories a day, if you, instead of eating 200 calories from a carbohydrate like pasta or rice, you ate 200 calories from a vegetable fat source, which is about an ounce of nuts instead. And that was associated with the 26% lower risk, roughly. And so it says 35%. That's basically that 10% change puts you from one to the two extremes. Yeah.
Why does the slide say all-cause mortality?
Oh, so this slide, actually, that is the endpoint. We also saw the benefit for prostate cancer. You're correct. I misspoke. So that was death from all causes. Yeah. So some of the slides are for recurrence. Some show prostate cancer. Yeah. So this one, as you mentioned, this is for recurrence. And so this is a study. This is done in CAPTURE, which is a prostate cancer registry led here at UCSF. And so men in CAPTURE who ate more cruciferous vegetables, which is broccoli, cauliflower, kale, cabbage, so about 1 serving per day compared to none, was associated with a 40% or 59% lower risk of their disease recurring. And I'm just giving you some examples, and then I'm going to talk about a trial that we're doing that applies this data. And so one last example is that actually, as Greta was saying, the recommendation is to obtain your nutrients from food instead of supplements, because we've actually seen some harmful effects of single supplements. And so this is a very new study that my colleague in the Department of Urology, Dr. Kenfield, led, and it shows that individual selenium supplementation, like on top of a multivitamin or anything like that, but a selenium supplement was actually associated with a very high increased risk of dying from prostate cancer after diagnosis. And so with all of this data, as well as some that June will talk about later in exercise, we're doing the Prostate 8 study here at UCSF, which is a website which will be a kind of a web portal for men who with prostate cancer to go to learn about all this information and obtain support and ideas for how you integrate this into your normal life. And so we'll be randomizing men to that versus usual care to test whether it actually helps people make the changes or not, and measuring a bunch of things, including the lifestyle habits and quality of life and body composition. And so this is a trial that we'll be starting again this winter as well. And now, so I don't know if any of you are familiar with Movember, but Movember is a very large kind of, question, yeah?
Are you studying selenium from natural sources like Brazil nuts?
So that study looked at total selenium intake. And the thing about selenium is that it's, well, for one thing, about specific things like Brazil nuts aren't consumed in that regularly, so it's difficult to study in large populations. The other thing about selenium is that because it's found in the soil, but our foods come from all different places now, that it's kind of like difficult to measure in diet versus supplemental intake. So that study looked at total between foods and supplements, yeah. And so Movember is a huge global nonprofit organization that funds over 800 projects in 21 different countries. And because of kind of the leadership that the Department of Urology here at UCSF has in prostate cancer care, they actually have a strong relationship with us and have been funding some really big, exciting new studies that are starting. And so one of those is called True North, which is, so the goal here is to improve survivorship care. So they've given over $35 million in the US to this project that's just starting. And so the Prostate 8 project that I just presented, that is one of UCSF's new little studies, is going to be kind of envisioned in a larger way in True North through the community of wellness that you see on the right. And so the idea with True North is that it's going to be a web-based portal for improving care for both men with prostate cancer and their families. And Dr. Cooperberg, who's a urologist in our department, is an integrated part of the design team for the actual web portal. And then Dr. Chan is leading, and myself are as part of it, is the building out the Prostate 8 web diet lifestyle intervention into kind of a larger community of wellness that will be tested and available in a larger way, is the vision. So this is all just kind of just getting off the ground, but kind of the direction in which we're going is to provide some of these mobile tools and use all the resources we have to help people learn about the role of diet and exercise, and then hopefully help adopt healthful changes to their habits. And so on the contrary to that is now Dr. Chan's going to talk about some of our studies that are more focused on actual supervised changes in exercise, so that we can look at the tumor biology in contrast to more behavioral interventions like I was just talking about. So June, I'll also say that, so I was a postdoc here until January, and I just joined the faculty, and Dr. Chan has been my mentor for quite some time now. And so she's definitely the ultimate leader in this field of diet and exercise after cancer.
Thank you, Erin. That was very nice. So first, I'd like to thank Peter and Suzanne and others for giving me an opportunity to share more with you all about the programs we have here. Peter said 15, 20 years ago he wouldn't have believed that we'd be prescribing diet and exercise for cancer survivors. I came to UCSF 14 years ago, Peter, so it coincided. He started getting convinced. He was integral in my recruitment here back in 2001. And actually, I did come to UCSF specifically to look at diet and lifestyle and the outcome, the impact on prostate cancer survivorship. That was the charge that I was brought here to work on. So what I'm going to share with you now is really quick little snapshot on some of our current research that we're doing right now. Erin had an opportunity to highlight some of our observational studies done in these large population bases that have led to these clinical trials that we're now doing here at UCSF and globally. So just to orient what the overarching goal is of our program here, looking at lifestyle and cancer survivorship, what I've put up here is a very rudimentary diagram. So if you follow on the bottom, this is years of following a patient after they get diagnosed, for example, with a cancer outcome, and you're looking at survival. So how many are still alive 5, 10, 15, 20 years out? So our whole goal is to bend that curve with a lifestyle intervention. We are not replacing this with treatments. I fully, this is to complement treatments and standard care. We just want to bend that curve, make your life better, see if you can push out your survivorship a little bit further, and good quality of life along with it. Whoops. So one of the challenges, though, in our research world here is, and ideally we'd like to study everybody for decades and learn and amass as much knowledge as we can. Oftentimes what happens, though, is grants come in 3 to 5 year packages, 1, 3, or 5 years, right? So we sort of have to adjust our ideal of what we want to study to what we can do in a certain time frame. And so what you're going to see in some of these trials that we're proposing is we're looking at what we call intermediate outcomes. A nice synergy that's going on right now, I would say, at UCSF, which is really bringing together the strengths of the clinical and the translational science, is that there's fantastic biomarker discovery and great basic science going on all around us. And now we're taking our population science, our clinical goals, first of all, that I just showed you, and our population science, and marrying that with all these great new biomarker discoveries and biological understandings about cancer progression. And so several of our studies are really leveraging that, and we're looking at novel biomarkers to really see, okay, I can't spend 20 years to tell whether or not exercise is going to make an individual live 10 or 15 years longer, but because my partners over here in the basic science have these great new markers, understanding about telomerase or PI3 kinase and the mechanisms of cancer progression, I'm going to see if I can affect those, okay? So those now become my intermediate markers. And if I can impact those critical cancer pathways that we're quite sure influence progression, then that means I've done something with my lifestyle intervention. So that's why what you'll see here are some studies that are really focused on those intermediate markers. So Erin highlighted a little bit about our work on diet and prostate cancer survivorship. I'm showing you here similar data from similar studies looking at, this is observational data looking at the benefits of exercise, the potential benefits of exercise after a diagnosis of prostate cancer for the outcome specifically of prostate cancer deaths. So we all knew exercise is good in general. What was unique about this finding was really pinpointing, in men with prostate cancer after they're diagnosed, if I start exercising more, I affect my prostate cancer death. That was the new finding in this paper that Dr. Kenfield reported in 2011. And what was also unique about this is it was specific to vigorous exercise, and that was kind of a novel clue at the time. So it's not all exercise in that study was associated with the benefit for prostate cancer specific outcomes. Just vigorous activity, which is something that gets your heart rate up, so running, swimming, jogging, etc. So I should say all exercise, all types of exercise, though, were beneficial for death in general, okay? So it's consistent with messages that you've heard before, resistance training, anything, brisk walking, that will help longevity in general. This was interesting because it gave us a clue that maybe exercise has a specific effect on the biology of prostate cancer progression. This finding is really nicely complemented in the same year by a paper that Erin led in a different study. This is the prostate cancer registry study she alluded to earlier, which is CAPTURE, which was led by Dr. Carroll starting in 1996. This was looking at walking pace. So again, this is self-reported walking pace after diagnosis and the risk of recurrence of prostate cancer. And there was a reduction in the risk of recurrence for men who reported a faster pace. So 3 or more miles per hour is their usual walking pace. This was nice, again, because it's consistent with that earlier finding that suggested that you need to do something that's getting your heart rate up a little bit to really impact prostate cancer biology specifically. So taking those two findings, we pitched a clinical trial to really investigate that. What is specific about aerobic exercise that is impacting prostate cancer biology? So this is a randomized clinical trial that we got funded, yay, recently from the National Cancer Institute. The goal here, we're going to have 150 men enroll, randomized. Half of them will have standard of care, and another half will be asked to come on site for 6 months to exercise with a very specific prescription that is targeted at increasing their cardiorespiratory fitness. And they'll do that for 6 months. So half of them will come on site to exercise 3 times a week for 6 months, and then also be given a guided program at home for 2 other days per week. And then the other group is usual care. And the outcome in this study is actually looking at specific genomic signatures that Dr. Carroll and Dr. Cooperberg and others in urology have validated as prognostic biomarkers in prostate cancer. So they're looking at the tumor tissue and looking at gene expression patterns specifically in the tumor and associating that with the risk of progression. So what we are going to do is look at those tumor markers pre and post intervention and see whether or not they change in a beneficial direction. And we're working with a partner from GenomeDX, which is an industry collaborator who leads in this area. So again, 6 months, usual care, aerobic exercise, looking at changes in prostate cancer biology. I should mention all of the men in this study are going to be men with localized prostate cancer who are opting for active surveillance, because that actually gives us the opportunity to study the tumors pre-post, since they're not having any treatment or removal of their prostate cancer. Any questions? Okay. So I'm going to mention one other clinical trial that's earlier in the development phase. This is funded by Movember, which Aaron gave you a little bit background on before. This is called the GAP4 project. GAP stands for Global Action Plan. Movember has 3 other global initiatives. Dr. Carroll and I have the privilege to serve on the steering committee for this project. So what's up here is kind of tentative. It's what we've decided so far, but we're actually still vetting the proposal. But just to give you an idea of what's coming down the pike and what we think is really interesting and exciting, it's going to be a supervised exercise trial in men with metastatic prostate cancer. So the one I just described is going to be low-risk prostate cancer patients. This is going to be men with metastatic disease. A similar idea in that it's a supervised exercise arm versus a usual care arm. Right now, the thinking is a supervised arm with the intervention. It's going to be on-site combination of aerobic exercise with resistance training for 12 months, kind of an ambitious goal, but 12 months for the intervention. And then I believe, we're still discussing it, but pretty sure the main outcome is going to be progression-free survival in these patients with metastatic disease. And I'll show you, we don't have any results, but there's our team. So we practice what we preach, and the GAP steering committee convened in LA this past end of July. And to give us all our flavor of what we're thinking about for intervening, the Movember group organized 2 group exercise sessions for the steering committee. So that's all of us right after we had our TRX session, and the next morning at 6:30 we had a spinning session. So actually along those lines, you know, we are thinking of doing the intervention as a combo, high-intensity interval training, resistance, and cardiopulmonary exercise. So it was fun to try it out. So I'm going to just wrap up here and tell you about one more clinical trial that is being launched by our colleagues in medical oncology. The PI of this is Rahul Agrawal. Aaron and I are co-Is on this. This is targeted at patients with prostate cancer being seen at medical oncology who are on ADT or androgen deprivation. The goal here is to randomize 80 men to a specialized clinic that addresses all the multifactorial symptoms that Catherine alluded to earlier that men on ADT face versus usual care. And they're going to do looking at sort of satisfaction, changing in symptoms, and a variety of physical measurements pre-post the intervention. This gives you an idea of the schematic for the intervention arm. So they're kind of rotating through sessions with exercise physiologist, a registered dietitian, and a symptom management specialist. So they have 12 months of intervention, and they go through cycles of when they're going to see each one of those specialists each month. Okay, so this is, again, addressing issues related. So men on ADT have a lot of side effects from ADT, so it's addressing ways that diet and lifestyle can offset some of those negative side effects of their treatment. So I just want to end by thanking all of our patients who have been participants in our studies and hopefully will be participants in these future trials, and a variety of support sources for our research. So thank you. That's our last slide, I believe.
We have time for questions now.
Oh, sorry, okay, great, thank you. At what point do you, you're doing all this cool research, what point do you say, on the clinic side, even though it's not perfect yet, wow, there we're seeing some stuff here, so Bob, let's go vigorous, man.
Yeah.
Let's do some vigorous exercise here, you're doing great on your little, lightweight walking, but even though it's not completely proven yet, maybe you need to up the ante on getting your heart rate up. At what stage do you kind of make that call, like we can start having those discussions with our patients? And that, as an example.
I feel like Catherine and Peter would be best.
Could you use the podium mic instead, please?
Sure.
Thank you.
And that they,
Keep these that mic live so you can pass it back and forth.
they also asked me to repeat the questions back so that we made sure everybody heard them. So the question is, a lot of this epidemiologic data is emerging, is early, and it's not rigorous, structured, randomized clinical trials. So at what point do we think about incorporating it into how we take care of patients?
Even as a hint.
So I think there are, one of the things we're struggling with right now on the clinical side is that in 2015 we're under mandate nationally to implement survivorship care plans for all patients as they complete treatment at Helen Diller. And that requires us to give them a care plan going forward. So a summary of everything that you've gone through and what are our recommendations going forward. I can tell you in my practice that there are hints of signal that I talk about with patients. So for example, I believe there's an association, not a causal benefit, of vitamin D levels with colorectal cancer. And that if patients are knowledgeable and educate themselves and talk with their primary care physician about screening for vitamin D deficiency, it is not unreasonable.
Right.
And similarly, I think in colorectal cancer, one example where it's less straightforward is the use of chronic aspirin therapy. So I think the diet and exercise data is pretty significant, that you're probably not harming yourself by exercising. And you're probably not harming yourself by eating a good diet. But with aspirin therapy and chronic aspirin exposure, there are potential downsides. So that is a conversation that I have with my patients, that there is emerging data that a subset of patients do respond or reduce their risk of recurrence by taking a daily aspirin. We don't know the dose, but this is something that you and your primary care physician need to talk about in terms of risks and benefits. There is a lot of variability, I think, even amongst providers in my group, providers in the cancer center, and there's a need for us to put forth some sort of consensus recommendations in terms of how we take care of patients, absolutely.
Yeah, because that's the wonderful thing about UC, you get both, right? That's the reason why I bring it up.
Yeah, and I might add that, I find this a teachable moment. The number one or two cause of death in men and women with cancer is frequently cardiovascular disease. So I think lifestyle modification is important for non-cancer mortality. So we've emphasized this certainly in the prostate program, because we do a lot of active surveillance, and we find a teachable moment. So I think diet and exercise are a good prescription for many patients, and we know which way the U.S. is going with regard to these practices. We're no longer, I don't think we have a single state that isn't obese anymore, right? So there's plenty of reason to change your diet and exercise. I think one of the questions, of course, is if you want to, I think we kind of know what to do about diet. I think one thing you didn't mention is about caloric calories. I mean, what did you give any prescription for caloric intake? It's been my impression some people lose weight, PSAs drop, but do you give any guidance on caloric intake? Because June, I'm going to ask you, if someone wants to exercise, do they just buy a pair of running shoes, or how are you telling them to go out there and be sensible about it? So maybe, Greta, what about calories?
I mean, basically the guidelines are really to be as lean as possible without being underweight. So those recommendations that they come up with are really focused on avoiding obesity, because that's probably one of the biggest risk factors for heart disease and cancer, So definitely calorie reduction is something that I'm going to recommend to patients that need to lose weight.
About the exercises, we should probably be clear about the exercise. They probably should see their doctor as a good.
Yeah.
So the question, so if I understand the question is,
Could you go to the podium, please?
this works, but you want me to go up there?
The video.
Oh, the video, okay, I didn't see that, yeah.
So obviously, if you haven't exercised, it's recommended that you start slowly and start comfortably. I could take the opportunity to share with you here at UCSF, there are exercise counseling services, and right now actually there's a service that's open for free up to 3 sessions or more of meeting with a exercise specialist if you are a man with prostate cancer, and they will help set you up with a plan and do a supervised program over that way at the fitness center right here at Bakar. And so please take advantage of that. So I think you need to do with a little bit of guidance, but some things that everyone can do is to walk, hopefully. I mean, if you don't have any other muscle joint issues. And brisk walking, as I showed earlier, the data from Erin has been associated with the benefit, so certainly that's good. To answer your question though, why are we, I agree with you, there's always this push-pull between what we already know for good health and what we're focusing on to advance the science. In the big picture, you want to prevent death, and we already know that a lot of these things that we've alluded to prevent death, mostly from cardiovascular disease, and even smaller changes have a bigger impact in cardiovascular disease than they do in cancer. So part of why we're doing this, I think, is because it's a lot harder. It's easy for me to go take a brisk walk for 20 minutes. Most people will do that. That's not hard, it's very social. But if you gotta really work vigorously for 30 to 40 minutes, that's a bigger push and a hump for everybody to get over. So I think it's in our interest to figure out is that what's really needed for cancer and to bend the curve for cancer. So.
Question.
In the nutrition guidelines, apart from the processed meat part of it, I didn't really see anything about salt. What's the thing about salt?
One of the do you want me to?
Why don't we have everyone come up here? Stand back, otherwise we'll.
So she's asking about limiting sodium, and one of the bullet points on the AICR recommendations are to limit processed foods high in sodium, and specifically that link is with gastric cancer. I believe that's the strongest link with sodium. So high sodium foods are most directly linked with increased risk of gastric cancer, not so much other types of cancer like breast cancer or prostate cancer.
I'm just surprised that it's not listed in sugar, because it seemed like for a long time salt was the big enemy.
Well, salt isn't associated with weight gain, whereas sugar is associated with weight gain because sugar has, it's a macronutrient, so it has calories. And so typically when people are drinking sugary beverages, it's empty calories, and so that's increasing body weight and obesity, which is a big risk factor for increasing cancer.
Yes.
I had melanoma and I went through the 12 months of interferon and PEG interferon. Before I went on the interferon and before I did the infusions, I went vegan, real food vegan. I didn't do packaged foods. And Dr. Dowd accused me of not taking my chemotherapy because my blood work was too good to be on chemotherapy as long as I had been on it. And nobody suggested going vegan, real food vegan, when I went on it. I read it through a couple of other places. I did talk to you, Greta, and you said go with more vegetables and stuff, but I just eliminated all dairy and all meat. I just did real food, and you know, I told Dr. Dowd, considering how much it cost, believe me, I was taking it.
Yeah.
And I was told every day, and I'm very full of it.
It's a great question, and I frequently get asked this question about being vegan, and our early studies with Dean Warner showed a big issue on what kind of diet, and we strongly believe in the vegan diet, and it was a positive trial that we did. But June, you may want to comment on this, because we get this all the time, and right now the recommendations are not, I have some concerns because the diet we prescribe has got to be one that people can accept and live with, and if the diets are too rigid, it can be a challenge for some patients. But what about vegan?
Well, I think Greta
No,
can
like-
address that, but
No, yes,
so
that's a great-
this is, I think, again, this is a little bit of the tension between the advice you might get if you have the opportunity to sit down with a nutrition counselor specifically or an exercise counselor and work out what's best for you and where you're at. And I think if you're ready and prepared to do that, it's great if Greta encourages more vegetables, maybe try vegan or something. But there's that tension when we're writing guidelines that just go out passively into big recommendations. I think one of the concerns I know Dr. Carroll has often voiced is if you say avoid all meat, there are some people who are just going to, that's too hard, so they're going to ignore every other 10 things on the list as well. So I do think you have to, be mindful when recommendations like AICR come out or things that we put, we're always thinking about that tension and that balance, because we want people to do things that, we want the larger masses to try to do at least a little bit, rather than asking for so much that everybody drops out. But the nice thing, about the services here at our cancer center is you could have an opportunity to sit down or come to a class or meet with Greta or an exercise counselor, and they can really hone in on that prescription for you based on where you're at. And I think that was also what Catherine was alluding to, of the need for more psychosocial services as well to help everybody. So right now, just to let you know, some of our interventions we're doing, like the focus on diet change or exercise change with the supervision, then complemented by a whole behavioral support program or behavioral intervention research. So you saw both flavors of that, both in what I presented and what Erin presented, because we recognize that to really sustain those types of changes, some people need more support.
Right, do you want to mention anything about the vegan diet?
Erin will jump in.
I'll let you.
Okay.
I'll let you.
I just wanted to add that, part of the reason, I think a vegan diet can be done very healthfully, and certainly people see amazing results and changes. But at least we don't necessarily recommend that also, because fish and skinless poultry and all of the studies that we've done have been not associated with any harm. And particularly, there's been a lot of studies suggesting a benefit of consuming fatty fish, like salmon. So it's not necessarily, the recommendations aren't necessarily for everyone to go vegan, because it might not even be that may not be better than, say, if you have lean protein sources like skinless poultry and fish. But if it works for you, then that's exactly what you should do too. So the evidence suggests that protein sources like mostly processed red meat we need to reduce, but others may not be as harmful.
The survivorship care plan sounds fantastic. Does insurance cover that?
Yes, is the bottom line. So all of the services that are proposed within survivorship care programs, nutrition, genetics counseling, visits with a nurse practitioner around planned timing of surveillance or periodic follow-up visits, symptom management, are part of what we currently provide within the cancer center. And oncologists are, fortunately or unfortunately, providing a lot of that care on an ad hoc basis with a whole lot of variability and without a whole lot of education or training or information about how to do it. So it doesn't necessarily change reimbursement patterns. It's a challenge from the cancer center standpoint, and we're working on some of the financial models of how to have a sustainable program from a financial and reimbursement standpoint. That's the cancer center issue, but for most patients, if these are real issues, and they're recognized by the Institute of Medicine and the American College of Surgeons and all payers, that cancer patients have a long-term and multitude and multidisciplinary requirements.
Well, many of the things that you mentioned are also covered in the symptom management group. Do you coordinate with them on?
So that is part of our goal, is to bring in all of these resources under a common umbrella. And it's a real challenge, you can imagine, to bring in the expertise from OSHA, symptom management, genetics, nutrition, physical therapy, and all of these things that we know that the data supports we should be providing to our cancer patients, but also to make that palatable and manageable to the patients, because you don't want every 3 months to be coming in for 6 different visits. You're always at the cancer center as a patient that's not an active cancer patient. So it also requires a coordinator of care.
And who is the coordinator?
So we're exploring different models for this. We're actually working right now with a consulting company that's doing some of this modeling for us in terms of what this looks like with our vision going forward. But across the board, the recommendation seems to be that a mid-level provider, such as a nurse practitioner or a physician assistant, would be the person that was really on the ground and being overseen by a medical director or a physician.
And the cancer center's got a big interest in navigators for their patients, and these would be piloted in at least 2 programs, maybe 3.
Well, Jeff Belcora's program has patient navigators. The
But
breast
this
cancer
is, so we work with Jeff. So this is a little bit than Jeff has, but these are navigators that will navigate the patient through the entire system from beginning all the way through their care. So Jeff Belcora, who mentioned, does a great job in decision support and has got very innovative, impactful programs for breast, prostate, and we'll think others. But these will be navigators who will sort of, patient comes in for their first visit and will help them navigate the system throughout the continuum of care.
I think that's fabulous. I had breast cancer, it was 14 years ago, but I called it my science project. I mean, it was-
Well, we're still working on it. Yes.
One of the foods that was listed as fine was tofu. But I have heard that soybean products are contraindicated for breast cancer. You guys want to say anything about that?
Well, I'll answer the question because I get that question
Yeah.
probably 3 times a day or multiple times a day. And, you know, the good news is I think the earlier research was a little bit controversial and we weren't so sure about whether soy foods were safe for women that had had breast cancer, specifically hormone receptor positive breast cancer, whether that might be contraindicated. And there's been at least 5 studies that have come out within probably the last 5 or 10 years that have looked at soy food consumption in women that have had breast cancer, and they've actually shown that they are not associated with a higher risk of recurrence. In fact, they may even be associated with a lower risk of recurrence. So sort of the bottom line with soy is that we say if you like to eat whole soy foods like tofu or tempeh or soy milk, it's fine to do it in moderate amounts, like a serving or 2 a day. I probably wouldn't recommend having 10 servings a day, and I would recommend to avoid like soy supplements. But eating whole soy foods has not been shown to increase the risk of recurrence. So I think it's fine.
Greta, is that true for triple negative?
It would be true for triple negative because the issue with soy is more around a hormone receptor positive breast cancer, and they haven't seen that with any kind of triple negative or hormone negative breast cancer that I'm aware of.
Yes.
What about soy intake with regard to prostate cancer?
For the most part, the studies with soy and prostate cancer have shown that soy is beneficial, and you probably could answer that more, but we don't tell men with prostate cancer to avoid soy. We actually, encourage it as part of their diet.
Do you have any ongoing studies looking at the use of phytoestrogens or soy-derived foods, sort of prospective studies to see whether there are benefits or detrimental?
In any specific cancer type or any cancer type?
Well, most specifically with breast and prostate.
We don't have clinical trial type studies. We have ongoing studies where we're amassing data on diet after diagnosis of cancer. Erin I don't think she had a chance to talk about it, but that's a goal for the Athena project here at UCSF, which is one component. Athena has many components, but one component is to collect questionnaire data from women with breast cancer and then follow them over time. And actually one of the projects is to hopefully add the component of collecting dietary data. We do that in prostate cancer as well. One of the challenges, as I think Greta alluded to, is just in our current population studies here in the US, there's not a high enough intake of soy to really look at that very carefully. The studies that have shown a benefit for prostate cancer tend to come out of Asian countries where the intake's much higher.
Another question?
Yes, can you touch on supplements and for I'm a surviving cancer patient with kidney cancer, but I have been taking supplements for quite a few years. I've been diagnosed in '06, but all my blood tests and everything are usually great. So should I continue with supplements? I'm basically a vegetarian diet with eating fish most of the time. Like beet
I
complex.
think looking at supplements is a very individualized thing,
Okay.
and to make general recommendations is really impossible to
Okay.
do, because you really have to look at a person's individual diet, what
Correct.
are their other health
Okay.
history issues. And the thing about supplements is generally the findings is that, I think what I've read is that they basically haven't shown to protect against cancer. However, you might be taking supplements for another reason, and it might be completely appropriate to take that supplement, but it's more individualized, I would
I see.
say.
Back there.
What is the latest research on sugar and cancer? I mean, there's kind of like this myth out there that sugar could feed tumors. And I wonder about that, particularly in regard to when cancer patients are trying to make up for the nutrition they're missing out on, and they're drinking things like Ensure, that's filled with dairy and sugar.
Greta, do you want to take that on, or June, or?
Well, I mean, I think you might be able to talk a little bit more about the sugar and cancer connection.
Or Erin. But there's a couple different pathways here. So one of the reasons that's already been brought up for why, a couple different things, that's why sugar's been implicated in cancer is one, just the obesity link between simple sugars, drinking a lot of sodas or whatever, obesity and cancer outcomes, cancer progression. So in that sense, it does not work in your favor. The other thing is for several of the cancer types, colon cancer, breast cancer, prostate cancer, at least off the top of my head, the insulin metabolism and insulin-like growth factor pathways have been implicated in cancer progression. And so there's a little bit of a leak going on linking sugary intake to impacts on insulin metabolism, which thereby could impact your cancer progression. So that's sort of our current understanding of the biological pathways. But I think the one that is probably where the science is more firm is really the understanding about the impact on obesity, and thereby that's a huge multifactorial metabolic impact on cancer progression.
The only thing, I mean, I don't know so much about like in the context of people who have lost a lot of weight because of chemotherapy, because I think one of the things that kind of where that hypothesis is coming from is more in the setting of people who are obese or inactive. The big thing is more inactive because they're not burning, their muscles are not burning the fuel that they're putting in, and it's being converted to fat. The other thing to think about is that a lot of those like Ensure, at least I think it has a lot of protein and fat as well. And so it's metabolized differently than like a sugar sweetened beverage, which is pure carbohydrate. And so it's kind of also about the food package and what you're eating with it. So I wouldn't necessarily think, I think that if you've lost weight, and I mean, Greta can comment, but I imagine that those few foods are, especially designed to help people do better. So it's more about, this idea of added sugars, sweets, desserts, sugar sweetened beverages, and really refined carbohydrates that really when you eat them, your blood sugar spikes, your insulin spikes, and then you get a big drop, and it can, disrupt the whole system. That's really what this sugar hypothesis is resolved around. Yeah.
Yes.
Just one last question from my side. On people making that switch to more exercise and diet, you talked about mobile, and mobile often is linked to a social, which is people sharing about, we're part of this community you see or whatever. We're trying to make this change and what's working and what's not, or we've all been diagnosed over the last 3 months with X, and here's what we're trying to do. Is that part of what your angle is in terms of what you're trying to achieve, is these communities and the social aspect?
Yes, I think that's clearly what I think we need to do, and I think for us, of course, serving the patient populations that we have to serve, a lot of what we'll do will be remote monitoring, sensing, rather than the classic drive into San Francisco, park, wait in our offices. And so I think a lot will be remote monitoring, social support, and guidance. I think this will be the new way to communicate.
The smaller trial here in prostate cancer, the Prostate 8 study, will have a component of a Fitbit community that we're testing in there. And then the Movember project, the whole thing, that's why it's actually dubbed, we didn't name it, Movember named it, it's community of wellness, because it's really grounded on the idea that you will make sustainable changes if you do it with your whole community. And so that's why the audience and the targeting for those interventions are really not just at the individual, but their entire family and friends and everything.
maybe last question before,
I have a question about nutrition, diet, weight management, and the whole 9 yards. All of us are very different in our metabolism and our medications, in the way that we move, our food and diet. So where would I go to get my own, how should I say, silhouette of what I should and shouldn't be doing, including diet, how much exercise, how many calories, all the whole thing, so I would know how to manage my weight.
Okay, so if you're a patient at UCSF Cancer Center, you would come to see nutrition services. It's part of your care, so it's at no cost to any UCSF patient with cancer. We also have the exercise counseling, which is available at no cost. And so you can find out how to make appointments and how to see us through the Cancer Resource Center, which is at the Cancer Center. Have you been to the Cancer Resource Center?
Yes, and I have an appointment with the exercise,
Okay.
but specific to my metabolism and my lifestyle, are you gonna be able to tell me how many calories and what I need to take in and how my medication affects the diet and expectations for
I'll
weight
do my
loss?
best. Yeah,
That's $1 million.
it might be more than one. It might be more than one visit, but definitely. And then we do have the classes, but it sounds like you're looking for specific information, and so you should take advantage of the services. They're part of your care.
Thank you.
And these services are available to anybody who's been treated at UC in the past for cancer, not necessarily for inpatient.
Yes.
Just a quick one. My adult son and I participate in Movember every year, despite the fact it takes way more than a month for me to grow a decent mustache. And I would love to be able to include in our social media outreach this year, maybe a link, just because I can say, I'm seeing at UCSF and for my prostate cancer, and here's some of the things they're doing that Movember focuses on. So
I can send you the True North, they have a link for so True North is the big program for survivorship for prostate cancer. I'll give that to Suzanne, you can get it out, I believe. So they had a press release come out in September just to brand the True North product. So they had a 2-pager with the
I could probably Google it too and track it down.
Yeah, at
Or
this
it would
point,
go to
yeah,
the-
so it just came out.
to
It
their site.
used to be called ASAP, a Survivorship Action Plan, but now it's True North.
I'll find it.
Suzanne Tier, some housekeeping items or?
Yes, thank you very much. Our wonderful panelists have prepared a handout, so please make sure that you get a copy of it. It's right on the table there that you can take home with you to put all of these recommendations into practice. And just want to thank everybody for coming tonight and acknowledge that many of you here in the room are supporters of the Helen Giller Family Comprehensive Cancer Center, and that your gifts, your philanthropic support enables a lot of this wonderful research that's conducted by our faculty. So thank you for your generosity, and we'll hope you'll continue to be generous. We do have coffee and dessert outside, so you have a chance to talk a little bit further with our faculty. And thank you for coming. Update on the game?
Well, it was 5-0 in favor of the Giants.
Six.
But that's,